Okay, so I'd like to just officially welcome people now to this, which is the second virtual participants meeting for the Uropath EQA scheme. So it is only the second time we've done this. So as organisers, we're on the steep part of the learning curve. So please bear with us, treat us a bit gently, and hopefully things will go to plan. So in relation to exemptions for this circulation, we had 404 maximum responses, which is 85% of the registered participants. And you can see the numbers of exemptions there, which remains quite low as an overall proportion of people in the scheme. Only one participant exempting from more than one case type. This just reminds me and gives me an opportunity to say that we don't police people's exemptions. It's really for you to determine that from your own personal practice. If you're exempt, you only get 2 rather than 3 CPD points per circulation, and your exemption should really be declared at your appraisal so they can be deemed appropriate. So that's exemptions, and now we'll get into the real stuff. So the first case, AB, was a partial nephrectomy, 75-year-old male, and it was quite a wordy macroscopic description with a slightly unusual appearance macroscopically, because there wasn't any obvious renal parenchyma, and there was a lot of fat in the specimen, and a few people picked up on the word necrotic in the macroscopic distinction as well. And of relevance, we didn't get any immuno provided with this case. So this is the overview scan of the slide, and there is actually a small amount of renal parenchyma, but it's predominantly lesional tissue and fat. And this is a fairly representative view. And on the left-hand side of the screen, there's a very prominent microcystic architecture, with a lot of the cysts being filled by blood. And on the opposite side, a smaller, more nested, solid appearance to the tumour cells. And if we go into the smaller nested area at higher power, the cells are oncocytic, and I've got regular round nuclei of varying sizes and nucleoli of varying sizes as well. There's focal binucleation, there's no mitotic activity or necrosis microscopically, and there's this hypocellular background stroma. And some of the cystic areas are highlighted here and aligned by similar oncocytic cells with nice round nuclei, no perinuclear halos or wrinkled nuclei. And then it wasn't difficult to spot this feature because it was very prominent in this tumour. There was a lot of infiltration of fat, and I've got 2 pictures of that to emphasise the fact that there's quite a lot of it. But again, a similar cytomorphology to already that described. These are the comments that we got. So a lot of people, over 100, were requesting immuno. We weren't given any with this case, which is something to bear in mind when we go on to scoring. 10 people saying not suitable for EQA, and a few other comments there. In terms of the free text comments, these are very selective ones because we've got a lot of comments on this case. I've already flagged the fact that some people had noted the presence of necrosis being described macroscopically, and this was potentially of concern given the diagnosis they might make. A lot of people commenting on perinephric fat invasion, that the tumour had quite a prominent cystic pattern, and some people went further to subtype this as the telangiectatic variant of an oncocytoma. And having had a look at this this paper, I don't think there's no clinical significance to this. It's just a pattern of that you see in oncocytoma. And it's probably analogous to the sort of patterns in CIS being more relevant to us diagnostically to make the diagnosis rather than it having clinical significance. A lot of comments about additional immuno, and the fact that people generally would not sign out a case like this without having done some form of immuno. And in a pink tumour with this type of morphology as CK7 and potentially c-KIT would be a reasonable sort of panel to think about doing, given the morphological differential. And then a comment down here that somebody was considering something a bit more weird and wonderful because it's an EQA case, but that just gives me the opportunity to say we're not trying to catch people out with cases here. And we put in what we get, so to speak. And if you are submitting a case, please put in all the info that you had when you had the when you actually made the diagnosis, so morphology and immuno. So how did we do? Well, we got very good agreement actually, even though it's a slightly unusual morphology, and there is extensive fat invasion for renal oncocytoma. The next most common diagnosis was tubular cystic renal cell carcinoma, which really should be purely tubular and cystic and not have more solid areas. And then there's a lot of other types of RCC subtypes, a few angiomyolipomas, and then down at the bottom there, response 14. That was a differential from somebody who favoured an oncocytoma and put renal oncocytic neoplasm needs immuno as in the differential. So if we score this case, I would encourage you to give a 1 or full marks for number 14, because that person will then get full marks. So John, do we have any comments on the...
No, there aren't any questions. You do sound a little bit like something from Doctor Who, so I don't know whether your broadband is suffering a little bit, but we are getting a little bit of stutter from your end, but no comments from anyone else regarding this case, so I think you can go on.
Okay, well, hopefully it will keep going. So we'll move on to there were a few secondary diagnoses, and we'll move on to, do people think that this is therefore scoreable? So we're well over the 100 there, so I can release that there, and we've an overwhelming majority saying yes. So we'll move on to this screen now, and if people can work through the list there.
I think that's probably core rate.
It is. I'm just trying to transfer.
John, can you say something? John, can you just say, because I've changed.
Oh yeah, that's fine. You're fine. We can hear you.
Yeah, I've changed over to my pods because that might help with the acoustics. Right, let's see what people made of this. So oncocytoma scores a 1. Renal tubular cystic carcinoma scores 0. Eosinophilic solid and cystic 0. Angiomyolipoma 0. Epithelioid angiomyolipoma 0. Chromophobe 0. Papillary 0. Adult renal cystic 0, collecting duct 0, cystic nephroma adult 0, acquired cystic disease RCC 0, hereditary 0, unclassified 0, and very good. You kindly gave the last one full marks, so very good. So that's the first case down. This is a paper I just wanted to draw to people's attention, if you're not aware of it, that covers a lot of the entities that we're going to see in this circulation, which is a nice read. And there's a companion paper. This is on the existing WHO entities, and there's a companion paper, again in modern pathology, on novel and emerging renal entities, and there's quite a few of these coming down the tracks. So these are nice papers to be aware of, and this publication or this PowerPoint will go up on the EQA website, so you don't need to copy these down. Right, moving swiftly on, case 2. This was a testicular tumor or a tumor in the testis of an elderly man, 90-year-old male, and we were given again quite a wordy description. There were multiple smallish whitish nodules in the testicular parenchyma, and we were given a scanned image of the NKX 3.1 and told that the OCT34 and CD30 stains were both negative. So this is the low power view, and going in a bit higher, you can see testicular parenchyma, very hyalinized atrophic tubules with no active spermatogenesis, not that surprising in someone of this age. And there's clearly an infiltrating malignant tumor with rather amphiphilic looking cytoplasm. And if we go to higher power in other areas, there's a cribriform morphology to the tumor. And it's got this amphiphilic cytoplasm, and the inset there shows rather monotonous big eosinophilic nucleoli. Here's another area showing a slightly different morphology with a bit of more columnar cytomorphology and some pseudostratification. And this is the immuno slide that we had to look at, and that shows diffuse strong positivity with NKX 3.1. Excuse me, here's a higher power to show nice nuclear positivity. So in terms of comments, 39 additional immuno, and as you'll hear, a lot of this relates to PSA and PSAP. Very few saying not suitable, in fact, very few other comments. So a lot of people put metastatic prostate adenocarcinoma in the comment section because in the drop-down menu we only had metastatic disease, which is something that we maybe need to consider when we're actually scoring this case. We didn't have something more specific than that. Some people commented on mixed acinar and ductal morphology, that the NKX was favouring a primary prostatic, although we weren't given any history in relation to that. Somebody there wanting to see PSA, and that was a recurring theme. A lot of people wanted more traditional prostate-specific markers. Somebody giving us the benefit of having seen some unusual things metastasize to the testis, and clinical history being quite useful, which we didn't have the benefit of. And then there were a small number of comments on expanding the differential. Actually, there are reports of NKX 3.1 being positive in some sex called stromal tumors, some Sertoli cell in tumors. So it's not 100% specific for prostate cancer. And a few other people also mentioning rete testis and epididymal adenocarcinoma as also being in the differential. And although this person didn't think rete testis adeno should be NKX 3.1 positive, there is a paper which I'll give you the reference to at the end of this, which had, these are extremely rare, of course, but did have some positivity for NKX as well. And it can also stain background Sertoli and Leydig cells in the normal testis as well. So this is what we got in terms of the responses, and very high agreement, 98% metastatic disease. Again, just to emphasize the limitations here of the drop-down menu being not 100% specific. And we were given the additional history of, prostate cancer by the submitting pathologist. A few, and it really was only a few people, used the other box. I was expecting there to be a lot more, and basically said more specifically prostate carcinoma metastatic rather than just metastatic disease. And then there were a very small number of people that had favoured sex cord stromal tumours of various flavours, presumably because of this staining with NKX as well. So there's a few ways that we can approach this case. We could potentially make the case to merge everything and say that, given that we didn't have all the immuno available that people might have wanted, that maybe we give everybody full marks, particularly given the fact that we don't exactly know what metastatic disease means, although we assume that the majority of people thought it was prostate. Alternatively, we could merge 1 and 2 with full marks and give 3, 4, and 5 half marks, or if you're feeling mean, you could give 3, 4, and 5 0 marks. Or you may feel that this is not a good EQA case in terms of the drop down being quite limited by being a bit nebulous, just having metastatic disease. So do we have any comments, John? I don't seem to have got any on my screen here.
Only someone using the chat function. So could you please use the Q&A? And that chat function was suggesting that this is not strictly an EQA case, but I'm not sure that 98% agreement on the correct diagnosis, actually 99.2%, if you merge 1 and 2, you could not say that that was not a good EQA case. I realize there's some NKX 3.1 is obviously not starting to be specific, but I don't think the tumor looked anything like a Sertoli cell tumor. It was high grade, nasty. So I don't think you could pass it off as a Sertoli cell tumor. It doesn't look anything like that. And the sex cord stromal tumors, again, didn't really look like it. It's obviously clearly a malignant tumor. So you might want to take that into account. But I think you've got 99.2% agreement. And I think that was probably quite good. The idea of this case was to really demonstrate NKX 3.1 facility, because PSA is often quite wishy-washy or even negative in metastatic patients who have long-term hormonal therapy. So it's something which you should be using more and more.
To reiterate that,
hang on a second, I've got lots of questions now. They're all pouring in.
They're all flying in. Yes,
it's fine for EQA metastatic prostate. Clearly, are we not supposed to give the most likely diagnosis, i.e. Matt here? A good case, it would be shame to drop this. Morphology trumps score. There you are.
Yeah, I think they're all
let's put it to a vote
points.
then.
Yeah, and let's put it to the vote. I was just being devil's advocate there. So let's see what you think. So is it scoreable? I suspect from those comments we can see what you're going to say. And yes, you think it is. Very good. So we'll score away. All right, we're nearly over 100. Okay, we'll have a look. So metastatic disease scores 1, other prostate carcinoma metastatic 1, and the rest 0. So you weren't persuaded by my argument, but it makes it a bit easier if we get a complaint letter. And this is the paper I was alluding to, which was recently published in the American Journal, which documents staining of prosteins, so P501S and NKX3.1 in testis and sex cord stromal tumors. So it's worth a read if you are using NKX3.1. Right, on to number 3. So this is another renal tumor. This was a sizable lump, 12.2 centimeters, and we were given quite a comprehensive immunolist, positive for CD117, E-cadherin, and diffusely positive for CK7, and negative for mentin, CD10, and RCC. And this is the low power, quite a pink looking tumor, and at slightly higher power, it's a mixture of eosinophilic and clear cells with an occasional tubular profile. And at higher power, not the nice round contours that we saw in the first case, a few coilocyte-like nuclei. There's quite a few nuclear grooves in this section or this view, and there's quite some quite nice perinuclear halos as well. And in other areas of the tumor that were a bit more clear, the cell borders are quite prominent. There's quite nice multi-nucleation and quite nice crinkly coilocyte looking nuclei. No necrosis or mitotic activity that I could see. We got a few comments, but not very many. Nobody really saying unsuitable. Selected free text comments. Morphology and immunoprofile entirely supportive of chromophobe. A few people raising the specter of eosinophilic variant, which is defined by the WHO as being almost purely eosinophilic. So you could argue whether this really got into that category, but it doesn't really matter in terms of prognostication or typing. A few people tried to grade this, but the current recommendations are that the ISUP grading system isn't used for chromophobe tumors. Some diehards still using Hale's colloidal iron. Someone showing a bit of EQA paranoia there, that it might be something a bit rarer, and make sure in these tumors you sample widely, especially a big 12 centimeter lump like this, to make sure there aren't some nasty sarcomatoid bits. They're the secondary diagnosis. So if there's any comments just before we whiz on to the it looks from my screen here that there's a rather unanimous yes, we can score it. So I'll just hit the scoring button. I think in my haste there, I actually skipped over what the differential was. So a very small number of people put oncocytoma, which you'd have seen on the so apologies for that, but I think it's pretty self-explanatory. There are only 2 differentials offered, just to prove it is a live performance. Right, we're up to 144, so let's see what people thought. So chromophobe getting 1 point and oncocytoma getting 0. Okay, so making headway here up to case 4. So this was a nephroureterectomy specimen, which could have been a little clue. And we were told that there was tumor related to the pelvic ileocecal system, and then we were given quite a comprehensive list of immuno. These weren't scanned, but they were described. So the tumor was positive for P63, 34B312 E-cadherin, EMA, CK7, CD10, and CEA, and negative for racemase. And there was a supplementary question. So just to warn you, when you get to the voting for this case, and this will be the same with other supplementary questions, The maximum for each part of the question is 0.5, and half marks is 0.25. And that's why, because of the second part to the question. This was the low power view of the kidney, and you can see the calyceal system here in the midsection. Little dots out here, the glomeruli. So there's obvious renal cortex on the left side, and this was the bit to appreciate. If you saw this, it became a bit more straightforward. This is one of the calyceal areas. If you look top left, the green box indicates which bit of the section taken from, and the inset down bottom right shows quite convincing urothelial carcinoma in situ, which was quite extensive within the calyces in this case. This is another area a bit lower down, showing again in situ carcinoma with underlying invasive disease. And this is a fairly representative view of the invasive tumor, which was quite solid and nested, and you got the impression that it was trying to keratinize in areas, and there were a few nice dyskeratotic cells with a few intercellular bridges or prickles. So the suggestion that there was squamoid, or at least squamous, or squamous and at least squamoid differentiation, and there were some gland-like spaces as well, where the pseudoglandular is certainly possible. And this is a nice sort of intermediate power cortex on the left, tumor medulla, and deeper bits of kidney on the right. And you can see the tumor quite clearly infiltrating in between glomeruli, and just to emphasize the point, there's a few glomeruli with tumor between. So a few people wanting immuno, not many people saying not suitable for EQA. And these are some of the comments. So this is quite a common theme here, that somebody had spotted the urothelial carcinoma in situ, which obviously helps in terms of the diagnosis. But quite a lot of people would have wanted some additional immunostains, particularly some urothelial specific markers or semi-specific. So GATA3 and Uroplakin-2 also mentioned, and a lot of people commenting on divergent differentiation, a few saying with glandular, a lot more saying with squamous differentiation, and then a few erroneous comments. This one here, P63 positive, which suggests squamous differentiation. Obviously that's not quite right, because that's going to stain urothelial as well as squamous tumor. And here's someone using capitals to emphasize their point, wanting more sections, but then saying if sinus fat invaded, it will be T4, but if it's sinus fat, it's T3. It's got to be perinephric fat to be T4. So how did we do? Well, there was very high agreement here for this being a urothelial carcinoma. A lot of people putting in the comments with carcinoma in situ in the background, and that's how the tumor was submitted by the reporting pathologist. The most common differential being collecting duct carcinoma, and the immuno. If I just go back to the, we were told that the tumor is P63 positive, which would be a bit unusual for a collecting duct carcinoma, and would sort of argue against that. And obviously the carcinoma in situ further argues against that. One person punted for squamous cell carcinoma. Again, the urothelial carcinoma in situ kind of trumps that, puts you in the urothelial with squamous differentiation. But it would be a bit harsh, I think, maybe to give that 0. Maybe people will consider giving that half, and maybe even full marks, but probably half. And then there were a few others. So let's see. Have we got any comments then, John, before
No.
No, okay. So we'll, do people feel this is scoreable? Yep. So that's 100% saying scoreable. So we'll move quickly on to the scoring. Okay, we're well over 120 now, so we'll see what people think. So full marks, 0.5 for urothelial carcinoma, 0 nil point for collecting duct, nil for squamous cell carcinoma. I tried. Papillary type 2, 0, and renal medullary 0 as well. Okay, so this is the supplementary question. So people were asked for the TNM stage, and as you can see here, almost 100% people going for T3, but there were a few others, a few outliers. So do people feel we can score this? And again, unanimous scoring, yes. Leave it a couple more seconds, but people are voting very well. It's we're getting through this nicely. So PT1 0, PT2 0, PT3 full marks 0.5, and PT4 0. Very good. So on to case 5. This case caused a bit of consternation and pages of comments. It was a nephrectomy from a transplant patient. So it was the native kidney from a transplant patient. We're not told why exactly it was taken out. And this was an incidental finding. And we were given some immuno, positive for CD10, vermentin, racemase, and very focally positive for CK7. So this is the low power shot, and we have gone into this case retrospectively in a bit of detail, and we think it's most likely that these represent the same lesion, so 2 sections from the same area rather than 2 separate lesions in the kidney. But you can see it's clearly a cystic lesion, and it's not very big. That's the maximum dimension. So this is a sub 5 millimeters, just over 4 millimeters in size, so very small lesion. And it's clearly multicystic, and there's also got some small tubules as well. And the lining epithelium is a cuboidal to flattened single layer of epithelium. At higher power, the nucleoli were quite prominent, and there was also some cytoplasmic vacuolation. That's probably better seen at the edge of one of the larger cysts, where you can see this vacuolation of the cytoplasm, but there was very little, if any, oxalate crystal either in the tumor or in the background kidney, and there was very little in the way of background cystic disease, at least in fact there was no background cystic disease, at least in these sections, and we're not quite sure what the background kidney showed. And here's a bit of hobnailing as well, again with some prominent nucleoli. And the background kidney was that of end-stage kidney, so nice thyroidization there, and no cystic change, and as I say, no oxalate in the background kidney. So a lot of people, 26 saying this was very difficult, 10 saying not suitable for EQA, and 26 people would have sought even a further opinion. And in fact, a further opinion was sought by the submitting pathologist. So that's giving us an idea of the level of difficulty, which is considerable. And this is a very comprehensive comment here, which takes us through the main sort of differentials and issues of this case. So thank you for whoever took the time to write all this in. but certainly raising the possibility of acquired cystic disease associated RCC as a possibility, although making the point that there's not oxalate or acquired cystic disease obviously in the background kidney. And one of the take homes, and raising tubular cystic carcinoma as one of the differentials. And one of the take homes of this case is, if you are considering tubular cystic carcinoma as a diagnosis, you need to make sure that it isn't a fumarate hydratase deficient RCC, which can have areas that are identical to tubular cystic carcinoma and have a very different prognosis. The prognosis of a bona fide tubular cystic RCC is very good, whereas that of the FH deficient tumors is a lot worse. So a few more comments. So in addition to FH immuno, you can do 2SC if you're lucky enough to have that when trying to diagnose tubular cystic carcinoma. I thought I'd better put in a few comments emphasizing the difficulty of the case. Here's a nice one to make you smile. I know it's not papillary, but adenoma isn't listed, and a little zit like this in a scarred kidney should not be considered malignant. So maybe a little zit will make it into the next WHO classification. And then another lengthy comment, but again, a very useful comment, raising the possibility of these so-called acquired cystic disease RCC-like cysts, which have been recently described as the likely precursor lesions of acquired cystic disease RCC, which show quite considerable morphological and immuno overlap with tubular cystic carcinoma. So summarizing all that, it's a very difficult, complex case, and unsurprisingly, we didn't hit the threshold of 70% agreement, which really makes it a kind of unscorable, but certainly a case of interest. The next most popular diagnosis was an acquired cystic disease associated with RCC, but this case lacked the oxalate and background acquired cysts that you expect to see in association with that condition. And a number of people in the others had mentioned these acquired acquired cystic disease RCC-like cysts, which I'll show you a reference for, because it's certainly a possibility here. And interestingly, when we dug back, this case was actually from 2016, so it's quite an aged case. It was referred to an internationally renowned renal tumor pathologist at the time, who favoured it being a tubular cystic renal cell carcinoma. But it was actually a couple of years before this paper on the RCC-like cysts was published. So there is a bit of uncertainty with the diagnosis here. So there's a whole plethora of reasons why we should exclude this from scoring, not least because there's a bit of uncertainty here about what the diagnosis actually might be. So if we whiz on to this, if you pick it is scoreable, we'll have to go back to that chart and scratch our heads for a long time, I think. So hopefully I've led you to the conclusion. So we're over 120, and thankfully people are agreeing that will not score that case. So I now have to whiz through all the scoring bits and get to this, which is a paper of interest that you might like to read on these acquired cystic disease associated renal cell carcinoma like cysts, which is a bit of a mouthful, but this is one of the pictures from that paper, which is not a million miles away from what we were seeing there. So it's a bit of an open-ender, that one. Did we get any comments or people wanting to?
I think someone felt that there were some answers which were way off, but I think the whole case is completely way off. So
yeah.
yeah.
we'll keep away from the degree of way offness, especially when we don't know what the actual answer is necessarily. Right, moving swiftly on. Number 6. So this is my last one for today. This is a TURBT specimen, 74-year-old male, had a history of high-grade urothelial carcinoma, and we were given a single immunodescription, CD56 positive, and there is a supplementary question. So when we're voting, again, the maximum for each part will be 0.5. This is a low power shot showing some blue areas and then some more hemorrhagic looking areas as well. And this is a fairly representative bit of the bluer areas. The arrows are denoting mitoses, and there were lots of those. The cells have stipulae, but some small nucleoli as well, and limited amounts of cytoplasm, and show some quite nice molding. And then there were other areas that would look quite different, where the cells were more were larger, had more voluminous cytoplasm, and included some of these rather nasty looking tumor giant cells, which a couple of people made the point they might have splashed a beta HCG, wondering about trophoblastic differentiation, which is not unreasonable. And this was a representative area shouldering the invasive tumor. And over on the left here, there's quite obvious urothelial carcinoma in situ, including some rather large giant cells as well. And that's highlighted in the inset bottom right there. And this is an area, apologies for the dust here on the section, but this is a pretty unequivocal organoid chunky bundles of detrusor muscle, which is infiltrated by the smaller elements of this tumor. So in terms of comments, 30 people wanting additional immuno, only one person saying unsuitable for EQA, and lots of comments. These are very selected ones, but basically they summarize what people were feeling with this case, that there was probably a mixture of small cell and then a larger cell component to the tumor. Some people felt the larger cell component was compatible with large cell neuroendocrine, others feeling that it was more usual type TCC. And without actually being able to see the CD56 stain, it's a bit difficult to interpret that one way or another. So they're not entirely surprising comments. A couple of people in relation to the staging, persisting in trying to substage T2 on a TURBT, and some people making the comments you shouldn't do that, and maybe in the near future we won't be giving a PT stage, we'll be giving a T stage on these specimens. And then another helpful comment by someone that I'll let you read through, but basically making the point that CD56 is not a specific marker of neuroendocrine differentiation, and it's a bit perilous to use this as your sole marker for neuroendocrine differentiation, particularly because it can be positive in some things that would be potentially in the differential. So that's a point well made. And how did we do? Well, we didn't hit the 70% agreement, but we do have potential to merge quite a number of these to similar entities. So this was actually submitted as invasive urothelial carcinoma with neuroendocrine differentiation, i.e. poorly differentiated neuroendocrine carcinoma component. So the submitting pathologist didn't actually commit one way or another regarding small cell or large cell neuroendocrine carcinoma. Another thing to say is the current definition in terms of nomenclature in the WHO is really to bottom line something where it's predominant small cell differentiation as small cell carcinoma, even accepting there might be some urothelial carcinoma as well. And that may explain why some people have gone for small pure cell versus the other option, which was TCC with some small cell. I think it's just important to re-emphasize that no matter how little, if there's a bona fide convincing morphological bit of small cell, you should have that somewhere in your bottom line, because that may well influence what the oncologist does in terms of neoadjuvant or adjuvant treatment. So in terms of scoring this, it might be reasonable to approach this by saying that anyone that's recognized that there's a neuroendocrine carcinoma component to this tumor is correct, and we won't go down the lines of saying whether it has to be small cell or large cell. That would be similar to the way we've dealt with these kind of cases in the future, or in the past, sorry. And there's a few others, a small number of others. This last one, number 8, I think that must have been a trainee or overseas, because it's got 0 here. So it's really only 5, 6, and 7 that we'll be scoring, and they probably don't merit a mark, given that they haven't picked up the neuroendocrine element to this. So if we move on, John, are there any comments about that?
There was just one comment. Just I'm not quite sure how I could say this. So isn't correct any small cell component makes it small cell carcinoma? No, I think the most people would recommend you giving a percentage for each of the components in a tumor, even if it's a 5% small cell. They're unlikely to do anything different with a 5%, but when it comes to 50% or higher, then they may do something. It's really the oncologists are as reliable a breed as pathologists and probably do completely different things in different centers, but giving the percentage for each one allows them to be informed.
Yeah, and the WHO makes it a bit confusing as well as to when to actually call it small cell. They say it's when it's predominantly small cell differentiation. So whether you can actually do that in a TUR specimen is debatable as well. But it's semantics, as John says, giving a percentage, but making sure that you're flagging any element of small cell is probably the most important thing to be doing. So if we don't have any other comments, let's see what people think in terms of scoring that. Okay, and we've a very strong bent towards scoring it, so we'll move on and score it. And remember, 0.5 is the highest you can give. That's full marks. Okay, we're just over 130, so let's see what we've got. So TCC with small cell 0, so that's full marks, 0.5. Neuroendocrine small cell 0.5 full marks, neuroendocrine full marks, and large cell neuroendocrine full marks. So I think we've poorly diff 0, urothelial carcinoma NOS 0, and paraganglioma 0, and the sarcomatoid is a trainee, I think. And on to the second part of this question, the staging. So with very high agreement here for T2 disease, with a persistent subset of people that try and substage the T2 on a TURBT, but I would suggest we could merge these as being T2. And we've got a small number of outliers going for different stages. So do people think this is scoreable, the stage? Yeah, unanimous. And we can stage away. So we'll just go through the scoring here. So T2 at least full marks, T2A full marks, although quite a lot going for half marks, but it has it. Full marks for T2B, and then 3A 0, 3B 0, and T4 0. I'm just looking across at the Q&A screen, and there's a comment. Apparently, the WHO didn't mean to make it a requirement for predominant small cell to be required for small cell carcinoma. And then there's another question: should we substage in biopsies? Well, no is the short answer to that. So you can really only substage T2 disease on a cystectomy specimen. That's that, and then we have the ship of Oxley, which is the queue that John's going to take over now and do the next 6 cases, and then he'll hand over to John for the prostate cause.
I've managed to put it onto the wrong screen, but I'm still off I go. So let's see, why is this not working? Oh, so AB7 is the first of my cases. We're told that they've got a complex renal cysts. It's a partial nephrectomy, and we're told that they have immunohistochemistry is both CK7 and 34BE12 positive, and racemase is negative. And this is what it looked like, a cystic area here with some papillary areas. And with the eye of faith, some of the nuclei are pushed up. It's probably best in this area, although it's slightly complex. It's slightly better here, like secretory endometrium. The nuclei are low grade, very, very small nuclei. Some wanted more immunohistochemistry. And these are the comments. And they talked about polarized away, a cup like CA9. And some people wanted more immuno. And some people are very sad that these will make up their day beautiful when it's dark winter's lockdown. But never mind. So these are the diagnoses we've got. We've got a clear cell papillary at 95%, a standard papillary 1 and 2, a multilocular renal cystic neoplasm of low malignant potential, a clear cell carcinoma, and a papillary adenoma. But with 95.2%, that seems pretty good. Have we got any questions, Nick?
No, it seems we are questioning.
Well, let's go on to the next one then. So is this scoreable? We got 95%. I'm going to be less generous than Nick. That's good. 100% scoreable. So let's score away. We've got over 113. I think let's score. So, Nick, are you writing these down? So clear cell papillary scores 99%. Oh, it's going up as we speak. Papillary not specified, got 0. Papillary type 1, 0. Multilocular, 0. Clear cell, 0. Papillary adenoma, 0. Type 2, 0. And yes, this was a case of a clear cell papillary, but just to highlight, there's a recent publication, or not that recent, actually, 5 years ago, talking about having morphology of clear cell papillary within a bog standard clear cell renal cell carcinoma, so you can get some borderline things. So that's where it's important, where you can do the racemase and high molecular weight cytokeratin. and a CK7. So moving swiftly on to the next case, another kidney tumor, I'm afraid. We were told it was a renal mass. It's from a female, 38, and no immuno was performed. At low power, you can see that there's a little bit of renal parenchyma around here, but the most of the mass is this fatty appearance. And on high power, there were some areas like this, more solid areas, but the majority of it was fat. And then this area, possibly a vessel, but it's a bit difficult to tell. So immunohistochemistry was required by 73 people, not surprisingly, and 12 felt it was unsuitable. And because it had a large quantity of fat within it, people were thinking down the liposarcoma, and then obviously doing an MDM2 for liposarcomas. And people would like to do a melanA or an HMB45. You could do a cathepsin K as well. It should be positive. But having said that, most people plumped for the angiomyolipoma, although nearly 10% felt it could be a liposarcoma. Some people felt it was epithelioid angiomyolipoma, but to be an epithelioid angiomyolipoma, there's no real cutoff for the epithelioid things, but you'd expect probably 80% epithelioid cells, and this was mostly fat. Other people felt there was a lipomatous tumor versus an AML would need immuno, hibernoma, and fat necrosis. Well, it wasn't really fat necrotic, and hibernoma is not right. So we'll probably, hopefully, we've split these apart so you can vote on all of those. Xanthogranulomatous pyelonephritis and an angiosarcoma were definitely the outliers. Are there any comments, Nick?
No, we seem to have dried up in terms of the comments.
people want to come to the end. So let's go. Let's see if we can vote on this. So is it scoreable? Oh, everyone's getting very quick at the yes, just about score. Some people are not quite so happy, but good enough to score. Right, we won't give any immunohistochemistry. So when we come to the scoring, please bear that in mind. And then you'll have the entities on your phone now. Just going to let a few more votes to go because I can feel lots of letters coming towards us, Nick, on this case, depending on how harsh people are voting. So AML gets 1. I'm quite sure. A liposarc gets 0. How is that? How is that going to work? How does this work then, Nick? I'm confused. For the epithelioid AML, there was a split between. No, it's not 0 because if you combine the 0.5 and 1, that gets us 51%. But the majority give you 0.5. So do we add 33% of 0.5 and 17% of 1 and give them a score of 0.56? How does that going to work?
Oh, it's moved.
So
I think 0.5, take the middle ground.
Oh, I think so, 0.5 for that. That's what I think that's acceptable. So let's put them down for 0.5. Let's move on quickly before somebody else votes. Lipomatous tumor. Again, let's give them 0.5. And then 0 for hibernoma and fat necrosis and xanthogranulomatous and angiosarc. Did you get all those down, Dr. Mayer?
Yeah, just.
So AB9 is the next case of testicular mass. Oh, a break from kidneys. And we're told that it's positive for CD117, negative for PLAP, OCT34, and CD30. And the critical thing is that the patient is 85 years old. And that's what it looks like. And there's some very atypical mitoses. And some large nuclei. Some edema, sort of myxoid background. More mitoses. You did like your mitoses, Dr. Mayer. And this is the thing which has misled a few people, or possibly not, is that some of the tubules had these cells filling them, mimicking germ cell neoplasia in situ. Not many more standard comments. So someone commented on the intratubular spread rather than GCNIS. I suspect lots of people did that. Classical features, edema, cohesion, lack of cohesion, giant cells. They would like to exclude lymphoma. I would want an inhibin. I'm not sure why I did that. So again, very high agreement on this case, 97% spermatocytic tumor. A few people wanted seminoma. Lady cell malignant, I presume that's why they was talking about inhibin, and a lymphoma was a differential diagnosis. So with that level of agreement, I think we're happy that we can score it. And I'm just going to go quickly on. So yeah, we can score this, and then the scores will be appearing I think it's a straightforward case, so I'll wait till it just gets to 100. So 1 point for spermatocytic tumor, 0 for seminoma, 0 for Leydig cell malignant, 0 for lymphoma. And now we're back onto the kidneys again, I'm afraid. So the next one, AB10, is a left nephrectomy, female, 74. Which is slightly old for these. They tend to be more middle-aged women. And we're told, very helpfully, that the stromal component is positive for ER and PR. You don't really need to look at the slide now. And it looks like this with some big cysts. Majority of it is cystic. There is some stroma knocking around. Has an ovarian type stroma. Some slightly hobnaily in places. Unusual selection. And I think there is a crossover between a MEST and a cystic nephroma based on the amount of cysts. But again, there's no real sort of defined cutoff between the two. And this is how we scored. So as these two entities are pretty much the same, depending on your defining how many cysts, and that's not really well defined, then it would seem logical to merge these two. And then the other ones, these two differentials are incorrect. And then the last one, I think is a differential. Someone's put in a trainee, but it's clearly not one of those. So if we merge these two, we should be able to score it with enough agreement and have, it's quite easy. So I'm just going to ask, are there any comments, Nick?
No comments, no.
I think everyone's fallen asleep. Waiting for the prostate cause, I suspect. Yep, we're going to score this. So if you can score it now, please. Cystic nephroma gets 1, MEST gets 1, lymphangioma gets 0, metanephric adenoma gets 0, and tuberocystic gets 0. So the next case is a cystectomy specimen for muscle invasive, 75-year-old. And there is a supplementary question again, so we won't be getting 0.5 for each of the 2 questions. And it was specifically asked, please state the predominant variant subtype in the diagnosis drop down to school full marks. And this is what it looked like, a cystectomy with some lymphoid follicles, and then there's the tumor here. And the tumor is comprised of these little papillary bits in lacunae, and theoretically you're supposed to see more than one little papillary bit in each lacunae to split it away from just a retraction artifact in a standard urothelial carcinoma. You could probably argue that the lacunae has more than one in it. And in the background, there's carcinoma in situ. The problem comes with the staging this later on. We ask you to stage it, and where does the muscle finish and where does fat start? So I suppose you could draw a line along here, but what about these muscle fibers here? And that's probably the inner bit. So this is probably outer muscle.
Well, the arrow there, John, was delineating that bit of tumor there, which was the outermost bit of the tumor. Yeah.
And there's areas of necrosis. Some people felt that splitting 2A and 2B on this was a little bit academic. Then some people noticed CIS. And some people just don't know what the TNM staging is off the back of the, surely this is not, should be stuck up in your office somewhere so everyone can access it quickly. And we asked you for the subtype in order to really highlight the importance of this entity, which is being recognized more and more. And clearly, most people recognize this as a micropapillary urothelial carcinoma. 98.5%, which is a startling degree of agreement for this when we've ever asked for a subtype. Other people felt it was nested, and some people thought glandular differentiation, and some microcystic. But it's clearly not any of these, and it's a straightforward micropapillary. So with that level of agreement, I think it's pretty easy that we can score it. Were there any comments? Sorry, I should have. Nick, were there any comments?
No, there's no comments.
There's no one.
We're getting a few retrospective comments that seem to take a while to come in. There's a couple of comments about the angiomyolipoma case that have only just arrived here.
Well, maybe we should, if you could just answer them individually, that's a pretty good idea. That's what I've been doing. Right, I think we've probably got enough people voting. Yes, everyone thinks we can score this. Don't forget it's going to be half marks, because half marks is full marks, if you see what I mean, because there's a second part to the question. I'm conscious of the time, so I'm just going to speed through this. So micropapillary scores 0.5, nested 0, glandular differentiation 0, microcystic 0. The next thing was the staging, and we asked you to use the scanned slide. So that's the image which I showed you just now, and you can see that the majority we're going to call it PT2B, but that doesn't really reach 70%. So we really do need to merge 2A and 2B in order to be able to score this. So next question, I'm going to ask you if you can score it. We answer everyone thought yes. And then they're going to ask you to score it. Don't forget 0.5 is the maximum you can get. Oh, what have I done? Well, that's sort of biasing everyone. I haven't had time to vote. Let's go on to the next one. So PT10. 2A is 0.5. 2B is 0.5. 0 for 3A. And this is talking about micropapillary carcinomas and reproducibility. So again, it's multiple nests in the same lacuna space and intracytoplasmic vaculation, including epithelial ring forms. So these are sort of signet rings, but with not mucin in the background. And then moving on to AB12, which is a foreskin. We're told a 64-year-old, it's a male, and then there's some descriptions, which you don't really need. And we're given a macroscopic photograph and a pearl stain. So this is the macroscopic, and it's orientated and pinned out because the clinician was worried that it could be PIN. And these are the two sections you've got with areas of ulceration and granulation tissue towards the glandular aspect of the specimen. Lots of plasma cells and scattered pigment, which is clearly iron on the pearl stain. Some people would like further blocks. I'm not sure. So some people commented there's some lichen sclerosis in the background. Some people wanted syphilis, penile melanosis. Well, penile melanosis is melanin pigment, and it's not iron pigment. I need to rule out syphilis. So again, extremely high agreement on this case. 98%, 98.8% wanted Zunes. A few wanted BXO. Someone wanted penile melanosis, but as I said before, penile melanosis is melanin, and this is iron. Granulation tissue with hemorrhage, I think that's missing the point of the differential. And granulomatous inflammation when it wasn't particularly granulomatous. So I think we should be able to score this with that level of agreement. And I think we will. And then on to the scoring for this. I think we're over 120. So Zune scores 1, BXO 0, penile melanosis 0, granulation tissue 0, granulomatous inflammation 0. At this point, I'm going to hand over to John. Are you there, John?
Was actually, just before you start, John, there was a comment there from somebody anonymously that they've recently seen a spectacular case of syphilis teeming with treponema on immuno.
Well, there we go. This case we went back to, and it was negative. It doesn't really look like this, I would have thought. Right, I think you have control, John. Do you have control?
I'm there, yes. I think I'm there. So you have to bear with me slightly. It's the first time I've done this. I'm probably feeling slightly like this picture at the moment rather than the other side, but we will go through the prostate cause, and I'm sure Nick and John will correct me if I get anything wrong along the way. Oops. So case AB13, clinical information, high PSA of 25.2, but a PIRAD 2 lesion, so not particularly worrisome on MRI. Big prostate, 140, some LUTs. And we were given a triple cocktail to look at as well. So that's the racemase stain red and the basal cell markers brown. So this is the area of interest for these kind of packed together glands here, which look like this at intermediate power. You get the impression of some condensing crystalloid-like material, back-to-back glands, quite a lot of expanded flocculent foamy type cytoplasm within that area as well. It was a relatively largish collection of glands, so 1.5 millimeters. So it was a significant abnormality within the core. Slightly higher power, fairly monotonous, bland nuclei, a very occasional, quite small eosinophilic nucleolus. And again, you can see this kind of more crystalloid material, certainly up here, the little kind of shards of crystalloid, as you can see there. This was the triple stain. So we got some entrapped benign glands down here. And then the focus was completely devoid of brown staining basal cells, and only showed a little blush of fairly granular, though, cytoplasmic amicus staining. So comments-wise, 15 people wanted a further opinion, but after that, only 2 people thought it wasn't suitable for the EQA, so that's fine. A couple of people said they're surprised that the racemase wasn't staining red because it looked like a cancerous area. Someone pointing out that crystalloids kind of pointed them towards it being adenocarcinoma. Atypical adenomatous hyperplasia, but we seek further opinion. That can be a bit amica positive, but tends to be a smaller area, and you still tend to see at least occasional basal cell in those kind of areas. Feature those are pseudohypoplastic carcinoma with foamy changes. And someone pointing out here that the amica in foamy gland type carcinoma is usually, can be negative or a lot less stained than the kind of microacina typical types of prostate adenocarcinoma, which was the highlighting kind of the feature of this case, really. Having said that, we reached 94% agreement that this did represent adenocarcinoma, 3.1% benign, and then some people called it ASAP because of the amica staining that wasn't what they expected it to be. So with 94% agreement, I suggest we can score this case. So if you would vote. Okay, and we're up to over 120. So 98% of people agreed that we could score this case. So we will go on to score it. And again, it's 0.5, the highest number, because we've got the Gleason grading supplementary question. Just wait for a couple more votes. Okay, so adenocarcinoma gets the full 0.5. Benign is 0, and ASAP is also 0. A few people, 20% of people thought it might have a 0.25, but nearly 80% of people thought it was 0.5. Sorry, 0, so ASAP gets 0. And then the supplementary question was to Gleason grade group it if it was adenocarcinoma, which we've agreed it is. The vast majority of people thought it was Gleason grade group 1, so 3+3 basically, although 5% of people thought it was Gleason grade group 2. Reminds me what we do with the Gleason grade groups, Nick, John, is it allowable to be one out?
Yeah, that's what we've said.
Yeah.
So I think this one, the not applicable would obviously score 0.
Yeah,
and then the other two you could merge together and they would score 0.5.
Okay, so with 90% plus the 5% there, I would suggest it's scoreable, which if people could vote. And we're over the 100 again. So total agreement that we can score this supplementary question. And if you could indicate which of your
I'm not sure we need them to vote.
Yes.
Otherwise, they may move away from the party line.
No, they haven't, John. You're all right. Right, okay, so we can score that as 0.5 grade group 1, and again 0.5 for grade group 2. And this is a quite good paper just from March of last year, highlighting some different types of variants of prostatic adenocarcinoma that is worth a read. This is the foamy gland type that we had here that shows again that it's less umbilical staining, and this is the pseudo-hyperplastic typical variant that can mimic high-grade PIN, but that is quite umbilical positive, so that helps you with the immuno and lack of basal cells. Okay, sorry, I should ask you, John, any questions that have come through?
Not relevant to this, no.
Okay.
So you're going to head over to me. So you're going to be my. So a few years ago, careful, don't press play yet. I go back a slide. Go back to the other slide.
Yeah.
So a few years ago, we showed some AI, beginnings of AI at the EQA session. So this is how a few years later it has moved on apace. And this system we're going to show you today is the EQA slides have been put through the Page AI system, which we're just trialing at the moment. So we're not using it live, but I just thought you might like to see how this is improved. And it does two things for you. It produces a point of interest if you press one button, and it does a quantification and grading if you press another button. So the short video is going to show you how this works. So here we go, John. So here's that case you just seen, and this is where the broadband is crashing. So here it is, and you'll see me first of all going to the point of interest and clicking it twice, and it goes straight to the area in these sets of calls, and you can center on it and it will show you the area which we're interested in. And then if you go to zoom out again and then go to the quantification, it'll analyze the area, and it tells us that it's Gleason 3 + 3 = 6, and it also gives you the length. I'm not quite sure the tumor length is measured at 3.55. I'm not quite sure how it's come to that, because that's not how we measured it. We measured it smaller than that. But you can see that it hasn't found any other tumor anywhere else in any of the cores. So that's that.
Okay. I think you were going to reassure people as well, John, that this isn't going to be an existential threat to their livelihoods, and that this is probably going to be an adjunct to what we do, and might lighten the workload rather than take it all away.
Obviously, Nick, I wasn't going to suggest such a thing, but it'd be quite nice to for all those arguments between the centers of what the Gleason grade is, that we can all turn around and say, well, the Page AI was a Gleason 3 + 3, so we shouldn't have these discussions. Okay,
thank you. So case AB14, prostate biopsy from a 62-year-old man. Hadn't had an MRI, and we were given a triple cocktail again to look at for the immuno. So this is the most area of atypia here. It looks a bit dark and crowded, and you've got these expanded hyperchromatic glands, look quite hyperplastic, some tuftings, kind of micropapillary areas, and then these slightly paler amphiphilic glands down here as well. Just focusing on those two glands here, they've got some eosinophilic nucleoli within them, and you've got nucleoli scattered in the hyperplastic glands as well. This was the triple stain, which I've rotated to be around the same way as the H&E stain slide, so it's comparable, with a nice kind of luminal granular cytoplasmic staining with amica in both the components. The discontinuous basal cell layer of this component, and lacking any basal cells within those two, maybe 3 glands. There's maybe a gland possibly over there, but of course there could be some tangential sectioning as well. 28 people wanted more levels, 15 were seeking further opinion. but only 4 thought it was not suitable for the EQA, so that's fine. Someone pointed out that the alignment of the H&E IHC lane was not the same, which is why I rotated the image. It was quite dusty, which I won't point the finger at anyone in particular for, Dr. Oxley. I think this will be controversial, difficult case. Someone talking about PDA versus PAA, unless it will be grade group 3, which is an interesting thought. And high-grade PIN with 2 associated glands that lack basal cells and therefore classified as PIN atyp. And this was someone that's done a lot of work to type this comment in, so thank you for that. That kind of really puts it in a nutshell what this case was put in for, pointing out that in cases with PIN atyp, there is a high rate of cancer on re-biopsy, or they could have other malignant appearances such as an MRI, etc. And references a nice paper down there as well. So 68.6 of us, so very nearly 70%, have described it as PIN atyp, with the rest of them just calling it high-grade PIN. There was 2% would have gone full out for adenocarcinoma, and 1.5% for ASAP. So I think we can probably score it and decide on how to merge these. You could argue of merging ASAP with PIN atyp because it probably have the same outcome for the patient, i.e. rebiopsy or at least closer PSA monitoring. And then to decide what we do with high-grade PIN and adenocarcinoma. Benign is probably not a good outcome for the patient because that would change, obviously, the clinical pathway. Adenocarcinoma with atypical intraductal proliferation doesn't really look like that. It's looked like more high-grade PIN. There was quite gaping glands rather than crubriform, lots of pleomorphism, necrosis, etc. Although that's the kind of halfway house between intraductal. So I think we can probably score it by merging some of those diagnoses. Do you agree? Okay, we're up to around 120%. So 93% of us agreed that we would score this case. So if we could score it. Wait for it to get over 100. Oh, it's jumped 100. Okay, so high-grade PIN equivalent so PIN atyp gets 1 point. Oh, high-grade PIN. Oh, it's literally neck and neck. Do we go middle ground, guys?
Well, I think you haven't got to go middle ground, just 0.5 because it wins by a hair.
Okay.
Quickly, move on before we change our mind.
Okay. Adenocarcinoma gets 0, benign gets 0, ASAP gets 1, which makes sense because they're combined.
They have to be combined.
Yeah, adenocarcinoma with atypical intraductal gets 0, intraductal gets 0. Great. For the supplementary question, obviously we haven't called it outright adenocarcinoma, so most people went for not applicable. Some people thinking it would have scored it at least grade group 6, and then a 3+4. Yeah, I'm not quite sure how we got to 3+4 from that, which is slightly worrying.
Oh, so we need. So we're going to score that?
I don't know. Oh.
So
no, there isn't a scoring option. Slido for that.
So we just done a full marks because it wasn't.
Yeah, because it's not a applicable one.
Okay.
Yeah.
And then I think we had some comments which have come up, which is basically about the AI system. That's fabulous, very cool demo. What digital platform is this on? You'd have to Google Page and you'll find out more information. what would the AI make of this case? Well, you're about to see it.
Okay.
Interesting, someone say that if you gave a diagnosis of high-grade pin on the last case, that was a result from a discharge from care. I'm not sure that is totally the policy of everywhere. It should provide is aware of pin, but not being of much concern. I'm not quite sure what the last one. So let's show you the AI. Now this is where you really are. This is incredibly impressive. So this is what you want in your background, because I must admit I thought it wouldn't be able to find it, but lo and behold, it has gone straight to that area with those couple of glands sitting there. And if you analyze it, because there is so little amount of tumor there, they said grading was not available. Or tumor, should I say, pin A-tip, because we didn't want to call it tumor. So there you are. So that's how AI could help you in the background. So the idea, there's nothing else in the core, just that focus it picked up.
Okay, which moves us on to the last case. Slightly elevated PSA. Again, we're given a triple stain from this 67-year-old gentleman. This is a representative area, just these closely plaqued dark areas or glands up here. There's one area, and you have these very expanded glands, absolutely full of cells. So kind of the 70% or more kind of cellular component within these glands. You get the impression there's some quite marked nuclear pleomorphism in some of these. You tend to get this kind of pleomorphic area on the outside of the gland, and then towards the middle of the gland, you get this almost paradoxical differentiation towards the middle. You can see some quite significant cellular atypia and nuclear pleomorphism in that gland, for example. You wonder about there being a slight bit of communonecrosis, although that's not, I don't think, entirely convincing. I couldn't see any definite communonecrosis throughout the biopsy. And then you had other areas, such as this one down here, where you've got some more classical infiltrating poorly formed glands with the usual kind of features, as you would expect, some nucleoli in here as well. So kind of two components admixed within this biopsy. This is the nicely staining triple stain, which shows you these expanded glands do stain up quite strongly with amica, again cytoplasmically towards the lumen. And they have a fairly continuous basal cell layer. Some of them are a bit more discontinuous. And then there's these glands intermingled that don't have any basal cells at all. And staying with amica, there's a nice kind of cribriform gland over there that shows that. So very few kind of comments on this. Not suitable for the EQA for one person, so that's fine. Free text comments really centered around it there being an introductal component of the prostate adenocarcinoma with typically invasive adenocarcinoma of kind of usual microacinar form. And then there was quite a discussion, as we thought there would be, on the grading or not grading of introductal carcinoma, depending if you follow the recent ISAP recommendations or the GUPS recommendations, and I'm sure it will be considered in the next data set that is being carefully considered by Dr. Oxley, but I think they're waiting for the kind of WHO to pronounce what it thinks about or its preferred option. And again, some of the comments, I won't dwell too much on this because I don't want to harm this person's mental health down the bottom, but does not want an extensive discussion about high grade grading of IDC versus not. This was a recent paper published in Histopathology this year, where the kind of pros and cons were argued between Morelli and Jonathan Epstein about whether we should or shouldn't grade introductal, which is quite a nice read for a direct comparison, really. So 70.7, so nearly 71% of us would record it adenocarcinoma with introductal carcinoma. The remaining the next kind of majority down would have called it adenocarcinoma. There's some adenocarcinomas with atypical introductal, so not quite amounting to the full introductal carcinoma. And then there's one person, I think at probably 0.3, that called it intraductal carcinoma with no invasive component, which there definitely was an invasive component, as I showed you that polyformed gland area. So again, I think we can score this, deciding how to merge these. Those two probably be merged with possibly this one as well on the scoring. So if you could vote. Okay, well above. So 99% of us agree that we can score this case. So we will go on and do that. Give it a couple more minutes for a couple more votes. Okay, so adenocarcinoma with intraductal, 100% of people agree, 99% of people agree, 0.5. Adenocarcinoma also gets full marks.
Oh, slow up, John. We're trying to write these down.
Oh, sorry. Adenocarcinoma, 0.5. Adenocarcinoma with atypical intraductal proliferation also gets 0.5. Intraductal with no invasive components, 0. And then moving on to the supplementary question with Gleason grading. So the majority of us have gone for 4+3, although we're kind of in agreement that there was Gleason pattern 4. It's whether there was more 3 than 4 or more 4 than 3, if you take those two together. A fully kind of Gleason 4+4, with probably the outliers being Gleason grade group 5 and Gleason grade group 1. So I think, again, we could probably score this supplementary question. Yep, 96% of people agree that we can score it.
So before we get into the score, I was going to say, before we get into scoring, because of the ISUP and GUPS disagreement, the intraductal component may not have been graded by some people. So you're going to get 3+4 or 4+3, depending on which way you grade. So we're suggesting we merge 3+4 and 4+3, and then the others are all wrong. Is that correct?
Or you give partial for the 4+4, if you know what I mean, being 1 grade group away from the merged 2, if you see what I mean, with Gleason grade groups 1 and 5 being incorrect.
Okay. Well, we'll let everyone decide on that.
Yep. Okay. Okay, let's have a look. So yes, Gleason grade group 1, 0. Grade group 2, 0.5. Grade group 3, 0.5. Grade group 4, 0. And grade group 5, 0. Is the majority decision.
And then we can move on to the AI system looking at this call. Because the tumor is basically everywhere in this core, when you press the focus of interest, it just goes to the bit which the algorithm thinks is the worst bit, which was here. But more importantly, it's the quantification that you'll be using this sort of system for, and it will tell you. Here it comes. It'll tell you that the Gleason grade it thought was 4+3 because it does not recognize intraductal cancer. It just sees it as pattern 4. And you can see that it's highlighting all the areas. And in the next level up of the AI system, which they're just trialing out. It'll actually, if you click on the pattern 3, 4, and 5 on the bottom right hand side, it will actually take you to those bits to see if you agree. And that's that one. All right,
Yeah,
shall I?
Finished? Yes. Let's do the final slides.
Okay, so the next part of this session is not going to take very long. It's just the feedback from the survey that we did talking about going digital in the EQA. So we had 210 returns, of which 181 were the full participants. And the questions were, how do you routinely report? And not surprisingly, 8 were digital, 20 digital and glass, 153 glass only. So the digital revolution has certainly not hit the UK. When will you be digital? Unfortunately, that was my fault. I didn't close the questions enough, and we got lots of others. So the percentages are slightly misleading, but you can see that 11% were digital already, 14% were digital in a year, 21%. But the big number which you need to focus on is that 53% of the respondents who were full participants had no plans to be digital in the near future or within 2 or more years. So these are the selected comments. They really fell into, the people who commented really just fell into 2 categories, really. Go digital, please. And then the people who were saying, well, I don't use digital slides, so that would be difficult. Other people saying that they've had problems with other schemes, because this questionnaire was really aimed because during the COVID, a lot of schemes went digital, and we had problems scanning the slides. So they were scanned with our scanner, and that's why they were all dirty, because I obviously didn't clean them quite as well as the Leeds people, because the Leeds scanner was offline due to the COVID shutting down the university. There were some comments about the quality of the actual way we view the slides. So the dirty slides, I'm afraid that was mine. Hopefully that will improve. And the cumbersome slide navigation, it's not quite as good as the proper digital slides. And then some person obviously doesn't take the EQA quite as seriously as they should be, as they do their EQA in bed. I might explain some of the answers we're getting. And when we asked you whether or not you wanted to move to digital, there was certainly a slight push to go to digital. So don't forget that 50% of these people aren't using digital, but they would be happy to move the scheme digital. And there are some major wins from our point of view. The admin of sending the slides around is difficult. So we did ask you about this, and it seems that 60%, I'm afraid there's still the percentage is slightly misleading because there's some trainee people, but only a small number don't get the slides on time. Sometimes, and 60% get them. And then extra sets are available from the EQA secretary. This is normally when people go on holiday and the slides sit in their inbox and they don't realize. So majority of people have not used it, the secretary slides. And then the submitting cases, we get a lot of themes of cases with remarkably similar things. So selecting cases which are showing a breadth and something which hasn't occurred in recent circulations is difficult from our point of view. And I think it's difficult from the point of view that some labs won't cut the slides and others, I'm not quite sure why people have never been asked, because we normally ask everybody. And then quite a lot of people either have not been asked or not actually ever submitted cases. I'm sure you have been asked. The secretary is normally quite keen at getting people to ask. So going digital would mean that we could use smaller biopsies and we wouldn't require so many spare sections. So the next circulation is going to open on the 15th of April, and in this there'll be the usual digital prostate cores, and we're going to include 2 kidney cases. I think they're kidney cases. I can't quite remember now, which are going to be pure digital. So you'll still get 10 glass slides, but the last 2 and then the prostate slide ones will be digital. And then we'll probably move to a 50% digital cases, depending on how many cases we have, which we do actually have slides for. And then following this, we'll reevaluate it at the participants meeting and aim to move to pure digital in the second part of 2022. So away, we have taken on board your comments that you'd like to continue with us with a glass and digital, but really the advantages of going pure digital for the point of view of admin and everything else, you don't get that advantage if you're going 50-50. So we're hopefully going pure digital in the second part of 2022. And just a reminder to save the date. So the BDIAP and having a meeting with BAUP in London on the 5th and 6th of November 2021, which is a Friday and a Saturday morning. It's planned to be a physical meeting at the moment. And the lineup for the speakers is still being finalized, but we expect to have some top line American speakers as well as some UK guys talking mostly about the WHO, which should have been published by then. So the new entities in the WHO, and which would be good to know. And we are planning to have the next EQA meeting, not at this meeting, but to have a virtual one like this session in order to really maximize the amount of speaker educational time, because the WHO classification will cover a large subset, and we don't really have time to do the EQA. So as ever, we would like to thank the EQA secretaries for keeping the circulations moving and the EQA Lite. I'd like to thank Paige as well for allowing us to do those, showing you that AI system. It's still, they're still working on it, but it's come on leaps and bounds in comparison to what we showed you a couple of years ago on a different system.